thank Dr. Shweta for including me in this wonderful IC. It's really covering the entire gamut of um, surgeries in cornea from the surface to the endothelium. नहीं कोई कोई आवाज नहीं. So my topic is anterior lamellar keratoplasty. When, what, and how. So when do we do anterior lamellar keratoplasty? Whenever we have a disease limited to the stroma. Okay, that means basically it's not just it's not a surface disease. It's not something which is involving the endothelium. It's essentially involving the anterior, mid, or posterior stroma, or all of it. Okay, so it could be scars, it could be ectasias of various types. It could be ectasias which have resolved with a scar and a hydrops, and even therapeutic indications like in certain infectious keratitis like acanthamoeba, etc., do well with lamellar keratoplasties. So it's important that we look at these patients on the slit lamp and make sure that the other layers are okay, and do the appropriate tests such as anterior segment OCT to make sure everything is in place and the endothelium is all right. If necessary, you can do a specular as well. So it's important to also understand the relevant new things in the anatomy of the cornea. We all know about the sixth layer of the cornea discovered by Professor Dua, which is essentially a predesmatic layer, something like a condensation of the posterior stroma, and it is really at this plane that we are trying to separate the stroma when you're doing a deep lamellar keratoplasty. We're not really detaching the stroma from the desmes, but it's actually from this predesmatic layer. If the pathology involves only the anterior stroma, say about 250 microns or lesser, then there are various ways to address it. You could, if it's very superficial, you could just do an excimer laser and ablate it if the residual bed is adequate. Otherwise, you can remove the anterior stroma either by means of a manual dissection, like is being shown in this particular video. So you can see that the donor cornea has been mounted on an artificial anterior chamber, and we're doing a lamellar dissection there as well. And then you basically put a 50% or so thickness of anterior stroma and suture it in place. You could also use an automated microkeratome to do the same thing, and that's when it's you could do away with the need for sutures. You could also use femtosecond laser to do the same thing. But if you're using a femtosecond laser or a microkeratome, you have to make sure that the surface is not very irregular. Otherwise, the bed that you leave behind will have the a Xerox copy of the irregularities of the surface. So you'll probably have to address the surface irregularity first before you do a anterior lamellar keratoplasty. So where could you do it? Superficial scars, dystrophies. I'm not seeing the timer. Flap, interface complications after LASIK, like epithelial ingrowth or some sort of if you've had a DLK or some other complication which has damaged the flap. Deep lamellar keratoplasty is the next important surgery in which basically you're removing the entire stroma essentially. And various techniques of deep lamellar keratoplasty have been described. The popular one is the big bubble technique, but there are several manual techniques also which can be used. Essential idea is that you remove the stroma anterior to the predesmatic layer and replace it with fresh stroma from a donor. So like I said, OCT plays an important role. It helps you to understand the depth of the disease, so whether to do a anterior lamellar or deep lamellar keratoplasty. If the deep stroma is involving the predesmatic layer or the desmes membrane, then you may not want to go down all the way till the Dua's layer or the desmes membrane, and you may want to do a slightly predesmatic dissection to prevent a perforation. Like in this lower OCT, you can see that the deeper layers have been damaged, probably from an old hydrops. This image is of a patient who's already had a DALC earlier, and you can see that the previous DALC was not all the way down to the predesmatic layer. So it helps you to understand if you need, after you remove the graft, whether there is scope for further dissection or you should just change the graft. Also, if you had an old perforation, any scarring, all that will help in planning. Topography also is useful because it helps you understand the extent of the disease on the cornea. So especially if you're dealing with an ectasia, you want to make sure you're encompassing the entire ectasia in your trephination. And I think topography with a large diameter is very useful in that. It's important to have the right instrumentation for trephination to obtain the dissection and as well as excision of the stroma. It's a good idea to have vacuum trefines for deep lamellar keratoplasty because you can go down to the correct depth, otherwise it's all very subjective, especially if you're trying to do a big bubble DALC. You want to be at the right depth when you introduce your cannula or needle. Femtosecond lasers, of course, are very expensive to refine, but yes, they do work beautifully well, especially for DALC. You can go for the mushroom cuts where you can remove more stroma and have a narrower posterior cut, and it will help you go to the desired depth. You can even make a track to introduce your cannula to get a perfect big bubble. And because the cuts are so well shaped, the new button also fits in perfectly like a manhole cover, and you can probably get better apposition with less astigmatism. Cannulas are very useful. These are big bubble cannulas. Many surgeons have designed some. Dr. Fogla has one, Dr. Sanikola, Tan, and many others have designed. And basic principle is that it's a cannula with a port at the bottom. So you're basically putting your cannula into the deep stroma paracentrally, and then you're injecting a small jet of air. The air finds its way through the deep stroma and detaches the predesmatic layer. You have dissectors also like these if you're planning to do some sort of a manual dissection. There are scissors which help to excise the stroma safely. So like I said, various techniques have been described, big bubble being the popular one. So this is what happens in the big bubble. You introduce air or sometimes even viscoelastic in the deep stroma and forms this kind of a feathery white bubble with a translucent center. Okay, this is called a type 1 bubble. This is a classic bubble, but sometimes if the air finds its way to the pre-desmus membrane space, it's more like a water bubble kind of a bubble which extends more peripherally, and that's not a desired bubble. That's called a type 2 bubble. So once you get a bubble, you remove some anterior stroma, you can puncture the bubble like so. It's called a brave slash. After that, if you want, you can introduce a viscoelastic in the interface. It's not mandatory to do this, and then essentially you are excising the stroma over dividing the stroma into four pies, and then you just excise them with a blunt tipped scissor like is being shown here. Then you go to your button, refine to size, peel the desmus membrane off it, and then you put your button in the bed and suture it with whatever technique is comfortable for you, interrupted, continuous. Femtosecond lasers, like I said, give you shaped cuts like these, and they help you reach the desired plane. And essentially, once you've got the bubble, the rest of the surgery is quite similar. And like I said, because the donor is also shaped exactly, so it fits very well and can be sutured nicely. So this is what a type 2 bubble looks like. You can see initially we're getting emphysema. Left one is a type 1 bubble, and the right one you can see we're getting emphysema, and then we get a water bubble. I'm not sure if you can see it on the video there, but after we excise the stroma, you can see that little bubble outside. That's the type 2 bubble. So if you have big bubble, why would you want to do a manual DALC? You don't always get a bubble like was just shown in the previous video. Extreme ectasias, the bubble doesn't go to the peripheral cornea. High risk grafts where you just don't want to have a perforation or a type 2 bubble, or if there's any other contraindication for a bubble like an old hydrops, etc., you may want to go for a manual. So traditional manual techniques are involve peeling layer after layer using a sharp instrument, but then there's a risk of perforation and you can end up with an irregular bed, and it's highly skill dependent. So we described this technique called the groove and peel technique, in which we make a partial thickness trephination. Here a bubble had been attempted, it didn't work. So then you basically do a scissor dissection underneath your groove, and you go all around, going with the closed scissor and then opening it. You can use any blunt tipped scissor like is being shown here. And then once you keep spiraling in circles till you reach this pre-desmetic Duas layer, which looks shiny and glassy like this. You expose about 2-3 cloacas. Then you just grasp that central island of stroma and use traction forces with the counter pressure from the other side to just peel that entire potential space open. And because you're using counter stretch forces which are distributed over a large surface area, it's less likely to perforate the cornea. So we've designed a scissor also for that with Joja Surgicals, which has a slightly narrower tip, and that works quite well. So this is just a representative picture. Again, in keratoglobus, it works very well because the attachments of the stroma are very weak, comes off like a LASIK flap. Therapeutic DALCs also it works well because the stroma is edematous and spongy. So this is just that patient of therapeutic DALC that did well. This is a patient of surface like was shown earlier, in which we did panis resection and did a manual DALC here layer by layer using an iris positive for dissection actually. And this patient actually did quite well, and we were able to save him from amblyopia. So it's not that perforation doesn't occur if you're very vigorous. Sometimes, especially if it's an old hydrops, you can have, but most of the time perforations can be salvaged in DALC to get good outcomes. And you can see this one patient has had a big bubble DALC and one has had a manual DALC, and both are looking equally good, clear interface and compact corneas. Thank you.
Thank you, Dr. Rishi. I think Dr. Prateek has a question.
Dr. Rishi, when you are doing manual ALK, what is the preferred method of dissection recipient bed preparation? Whether it is with the help of lamellar dissectors, as we it's a closed, or whether you open it and with one hand you do a dissection with crescent. How
No,
do
no,
you
I
do it?
do on the recipient you're saying.
Yeah.
Recipient will be an open dissection only. Yeah,
Okay. Don't you
but
think a
uh,
closed dissection with the help of a lamellar dissector would give you a better interface, a
it
smooth
might,
bed?
so that could be done, but then you can't be sure that you're removing the entire pathology. So
Exactly.
after you remove, then if you're left with something, then again you'll have to proceed.
Okay.
So I
Yeah.
just go with the like eyeballing kind of a thing, and
Okay.
according to that, I decide how much to go deep in the donor.
Okay.
I don't do too much of anterior lamellar keratoplasty. They're very limited indications
Yeah.
actually.
Exactly. Okay.
Yeah.
Very nice presentation. Just wanted to ask you if you are doing anterior, if you are doing an anterior lamellar keratoplasty in indications like trachoma, where you have Salzmann nodular degeneration above it, do you, when you do them, do you actually get the epithelial issues later on as well? And if you do get, what do you combine your surgery with, an amniotic membrane, or what is usually your way of dealing with it?
So
Why
if
would
it's Salzman, what in my experience it doesn't recur so easily, especially if you've taken care of the stroma and you've regularized it. Of course, if there's an underlying surface disease, that will have to be addressed. But I think you'll have to just do it on a case-to-case basis. If there is a surface problem, you have to address it. But if it's just a leukoma with Salzman, I wouldn't do anything else. I'd just do a DALC.
Yeah. Thank you.
Yeah.
Thank you, Rishi.
Thanks.
Any questions? Till the time Dr. Prateek is getting his thing ready. Rishi, any tip for opening up that thing? I still get scared when I have to do that slash.
For the brave slash, I
Yeah.
think the one of the important tips is if you can put a viscoelastic on the surface and mark the point of entry where you're going to make the brave slash, and just put viscoelastic. I think that makes the escape of air a little slower, and that has made a difference in my cases. And of course, when you're going in, just keep the blade in one direction. If you tilt it and you allow the air to escape, that's when the desmids will come back. So if you just keep it, the air doesn't really come so easily. It comes out gradually. You can go with a keratome. Yeah. So it's been described by Professor Sanikola. I've not really tried it, but it should work. Yeah. I don't do much big bubble only nowadays. I just do this technique most of the time. Yeah. It's basically you'll start seeing the layer. Stroma has that whitish fibrous kind of a look, no? Once you reach the predesmatic layer, you'll start seeing more clear kind of a layer. So you will see stroma. Matlab, basically, it's not that it's not there. I think it's adherent at the peripheral area. So I've seen that glassy layer even in very peripheral dissections. ऐसा नहीं है. So you can do it.
So, do you find any difference in the frequency of DM perforation in type 1 bubble and type 2 bubble?
Yeah. So basically, if you get a type 2 bubble, it is going to be a complicated surgery. If you've got only a type 2 bubble, you could theoretically dissect the entire stroma off using some sort of a manual technique and then just puncture the type 2 bubble and leave it.
So, is there any tip to get type 1 bubble, not the type 2 bubble?
So you have to select the cases carefully. In my experience, deeper scars, macular dystrophies, these are the cases where you end up with type 2 bubbles more often. Keratoconus is very rare actually. And the second important thing is you have to be in the right plane when you're injecting air, and don't see how your air is going in the stroma. If it is tending to come back into the cannula, into the track of your cannula, or if it's going circumferentially, then you're not in the right plane. Then probably instead of continuing to inject, you need to change your location and try again.
Thank you so much,
Thanks.
Rishi.